Hello, and welcome to tonight's webinar. This evening, we are kicking off the Immune Deficiency Foundation's Ask the Experts series. You'll hear a brief presentation followed by a more in-depth Q&A opportunity. Tonight's feature is Managing Multiple Conditions, led by Dr. Ramsay Fuleihan. We will learn more about primary immune deficiency, addressing symptoms exacerbated by other major complications and comorbidities, as well as facilitating communication among different specialties and systems. My name is Kat Stieber, and I am the Program Manager, Community Outreach here at Immune Deficiency Foundation. On behalf of the Foundation, we want to thank you for tuning in tonight to our virtual event. We created this webinar series knowing that primary immunodeficiency is complex, and our experts could talk for hours about the complexity of immune deficiency. But by focusing on our audience's ability to ask questions, we are creating a learning environment where our community members can guide us on what's most critical in their journey. Those are items we'll prioritize tonight in our time together. Before we get started, I would like to share a few items to keep in mind for our Zoom program. This evening, we are using Zoom webinar and Zoom webinar features. And our attendees should be able to see the slides and hear the presenter and myself, the host, speak. However, attendees will not be able to activate their video camera or their microphones. That means all of your questions will need to be typed in the Q&A box on the control panel of your screen, and they will be read out loud on your behalf. And we will try to get to all of the questions we are able to. As we begin to brainstorm questions, please keep the following in mind. Questions should be relevant to today's topic, and questions that don't pertain to today's area of focus should instead be submitted to our Ask IDF platform. And I'll provide you a little bit more information at the end of tonight's program on how to do that. Additionally, questions should not contain any personal health information. This includes things like medical history or lab results. Lastly, we ask that no questions be submitted that name specific brands of medication or providers. I apologize. Okay, please remember the information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. And as always, we encourage that you seek the advice of your physician or other qualified professionals. Never disregard professional medical advice or delay seeking it based on information provided during an educational event. And this meeting is made possible by our wonderful sponsors. So we're going to take a moment to thank them. It is due to their partnership and contributions that we can provide programs like this for the PI community. So please join me in thanking today's sponsors. And now I am so pleased to introduce our presenter for today, Dr. Ramsay Fuleihan. He is the Clinical Director of the Division of Pediatric Allergy, Immunology, and Rheumatology, as well as a Professor of Pediatrics at Columbia. Welcome to today's presentation, Doctor. And I'm going to turn it over to you. You are welcome. Thank you for being here. We are excited to get to it. So I am going to turn my camera off and my mic and stop sharing my screen. And that way you can start sharing yours.
Great. Thank you very much, Kat. Thank you for the introduction. Welcome, everybody. Thank you, the Immune Deficiency Foundation, for inviting me to speak today and for arranging these talks. We'll have some introduction for you about some very relatively common immune deficiencies and complications, just to set the stage for your questions. And really, the most important thing is the questions that you have that I will try to answer. I have served as a consultant to Takeda, Horizon, Pharming, and Grifols, but I won't be discussing any specific products today. You know, the immune response is there to protect us against invading pathogens. We can clear pathogens that are outside cells and their toxins. We can also kill cells, pathogens inside cells, such as virally infected cells as well. The immune system also surveys for malignant cells and plays a role in killing them, but can also result in allergic or autoimmune disease. So it is our friend, but in some cases it can be also our, the cause of some diseases. Primary immune deficiencies encompass a large number of gene defects or disease conditions. There are over 485 different diseases or gene defects, and each of them is rare, but altogether they are not so rare. They affect one or more component of the innate or the adaptive immune response. The innate response is what works initially, immediately after an infection, and it's something that we sort of inherit and changes over generations, whereas the adaptive immune response works after the innate immune response and also has some adaptation within the same individual, not over generations. And it's a much more specific immune response. If there's a problem in either component or both, patients are then have an increased susceptibility to infection, to autoimmunity, inflammation, sometimes malignancy. And more recently, we've recognized genetic causes of immune dysregulation and autoinflammation that led to changing the big name into inborn errors of immunity. So genetic defects that affect the immune system, of which primary immune deficiency is an important component. So the International Union of Immunological Societies classified these inborn errors of immunity into 10 subgroups. The first is immunodeficiencies affecting both the cellular arm and humoral antibody arm of the immune system, so combined immune deficiencies. Second is combined immune deficiencies, but they have associated or syndromic features. The third is probably the most common, the predominantly antibody deficiencies. There are diseases of immune dysregulation that cause autoimmunity, sometimes both autoimmunity and immune deficiency. There are defects of the phagocytic system, neutrophils, defects of innate immunity. Autoinflammatory disorders can be characterized by like periodic fevers. Complement deficiency is also a subset of defects of innate immunity. Bone marrow failure, because all the cells actually with the immune system start out in the bone marrow, so it can infect the immune system. And the 10th group, very interesting group that may not necessarily be a genetic cause, but it's more of an autoimmune condition that then leads to a disease that looks like a genetically inherited immune deficiency. The first immune deficiency to be described as agammaglobulinemia or X-linked agammaglobulinemia in a boy was described by Dr. Ogden Bruton now more than 70 years ago. The patient had absent gamma globulins but suffered from recurrent infections. He then transfused him with plasma and reduced the frequency of infection. Later, we learned that it's a defect in B cell development. There are no B cells, lymph nodes, or tonsils, and the gene defect was identified to be a tyrosine kinase, so a signaling molecule, and they named it after him, Bruton's tyrosine kinase. There are cases of agammaglobulinemia that affect men and women equally, or boys and girls equally, and they also result from defects in B cell development. The gene is necessary for B cells to develop, and so you get no B cells, and exactly very similar phenotype to X-linked agammaglobulinemia. Of course, X-linked agammaglobulinemia is more common because you just need one gene to be affected. Males only have one X chromosome, and then they would have the disease, whereas their mothers, sisters might be carriers. The mother usually is a carrier and has a another healthy X chromosome, so are not usually affected by the disease. The most common symptomatic immune deficiency is common variable immune deficiency. I could say the most common immune deficiency is IgA deficiency, but most patients don't suffer too many infections or complications, whereas common variable immune deficiency, all the patients have symptoms, and it is the most common symptomatic immune deficiency. It's not really a single disease, but we call it the phenotype. It's characterized by having a low IgG and at least one other immunoglobulin being low, either IgA or IgM. If IgG is a low on its own and IgA and IgM are normal, we call it hypogammaglobulinemia. It might be more semantics than anything, but to really be called common variable, you have to have more than one immunoglobulin be low, but for sure IgG has to be low. And the preference is for IgA to be low with the IgG, but it's accepted that IgA can be normal and IgM is low. Patients tend not to be able to make antibody. Isohemagglutins are antibodies to blood groups, but also if there's poor response to vaccines. We usually don't make this diagnosis until the patient's at least 2 years of age. We want to make sure it's not another inherited immune deficiency or a transient immune deficiency in early childhood. And then we call it common variable immune deficiency. Now, we have been discovering genetic defects that lead to conditions that look like common variable immune deficiency. And when those are identified, they are classified as their own disease, and common variable remains, sort of without a genetic diagnosis. But there are many, many known genetic defects that give you what looks like common variable, but they have specific features that identify them from other cases of common variable immune deficiency. The peak onset is in the second or third decade of life, but it can happen earlier or later in life. As I said, a low IgG with at least one other immunoglobulin low, IgA or IgM or both. The immunodeficiency seems to evolve over time. There are usually recurrent sinopulmonary infections, and they're usually bacterial. Some patients get granuloma formation. They can develop autoimmune disease, GI disease, endocrine disease, and autoimmunity against blood cells, like the platelets or red blood cells. But about 10% of patients have no history of infection. They have to have some other immune dysregulation, autoimmunity or so, with the low IgG and IgA or IgM to be called common variable immune deficiency. So this is a report from Dr. Cunningham Rundles. It's probably one of the largest groups of patients reported. And looking at the complications that the patients have, about a third have only infection with no other complication, sort of a classic immune deficiency. Another 30% or so will have chronic lung disease. And a third of those would be bronchiectasis, which is sort of chronic and long-standing. Again, about 30% have autoimmunity. Half of them would be immune thrombocytopenic purpura, about 7% with autoimmune hemolytic anemia. About 15% will have GI disease, either inflammation, inflammatory bowel disease, or malabsorption. Can also have liver disease with hepatitis. About 10%, almost 10%, granulomatous disease, lymphoma in about 8%, and other cancers in about 7% of patients. About 8% of the patients had undergone a splenectomy, probably for a large spleen, maybe associated with immune thrombocytopenic purpura and other autoimmunity. This study showed some complications compared some complications in common variable immune deficiency with X-linked agammaglobulinemia. So X-linked agammaglobulinemia, the patients make no antibodies whatsoever. In common variable, there's some immunoglobulin and maybe even some antibody being made. And this shows that a lot of these complications are not just because there are no antibodies and poor antibody function, because only a subset of them are associated with X-linked agammaglobulinemia, whereas the large majority of these pulmonary complications are associated with common variable immune deficiency. So there are other factors that affect the development of these complications, not just the absence of antibody. How do we treat antibody deficiency diseases like common variable immune deficiency, X-linked agammaglobulinemia? Is to provide antibody replacement, either intravenously, and we usually start with 500 to 600 milligrams per kilogram every 3 to 4 weeks, or subcutaneously, and doses end up being about 150, 200 milligrams per kilogram every week, but you can take more each time and do it less often, and there are forms of sub-Q that can be delivered every 4 weeks. So obviously in agamaglobulinemia and common variable immune deficiency and other hypogammaglobulinemia cases, other combined immune deficiencies where they don't make antibody, and then even in more subtle antibody deficiency, like the specific antibody deficiency syndrome, especially if we've tried other forms of treatment like antibiotic prophylaxis and they failed. So what's the best dose or best trough level? And a study done in the United Kingdom found that trough levels were not as important as the clinical response, and they kept increasing the dose of immunoglobulin replacement until the patients were free of infection. And they found a much wider range in dosing and trough levels in common variable immune deficiency compared to X-linked agamaglobulinemia. And that makes sense because, again, agamaglobulinemia patients have none. And so whatever you give them is presumably, functional, good antibody. Whereas common variable immune deficiency, it's a combination of what we give and what they have in their system. And so you can't compare the levels between two different types of patients. So anyway, while we like to see trough levels with IV of IgG more than 800, it's more important that the patient is free of infection than just meeting that trough level. And with sub-Q, we try to go a little bit higher because the levels are stable, and it's not as much a trough level as what the level is all the time. So we like to see 1,000 or more. So how do we manage multiple conditions when we have immune deficiency, especially we have complications? And I think the most important thing is to keep up with the management of the immune deficiency to try and prevent complications. Now, it doesn't mean that getting your immunoglobulin treatment or other treatment on time always means you won't get complications, but you certainly reduce infection and any complications that infections can cause. It's important to keep up with your regular visits and maintenance of your health by your primary care physician, not just the immunologist. And of course, all of us need to maintain a healthy lifestyle, but more so somebody who has immune deficiency. We want to prevent type 2 diabetes, chronic lung disease, heart disease. So avoid smoking, don't limit alcohol use, don't get involved with recreational drugs, maintain a healthy diet, regular exercise, all these help. But still, complications do happen. And autoimmunity may be one of the more common ones, especially immune thrombocytopenic purpura, ITP, autoimmune hemolytic anemia, and less often autoimmune neutropenia. So these diseases initially were treated by steroids, but actually some physicians noticed that while they were giving their patients who had immune deficiency and ITP a long time ago, when they were giving them gamma globulin, the platelet counts went up. So then they tried IVIG and with higher doses, and that seemed to be now is the first line of treatment for ITP. So somebody who's getting IVIG and needs to get a higher dose, well, that's more of a good thing in terms of IVIG. It's not going to hurt the immune deficiency. Hopefully, it treats the ITP, but sometimes it doesn't. And so the next line of therapy is to use anti-B cell antibodies. There are a couple of options now for those. And the idea here is that you wipe out the B cells that make the autoantibodies, but you can't select out those B cells. So you're going to wipe out all the B cells, even the ones that are making normal antibodies. Our bone marrow is always making new B cells. So this is meant to be transient. And as the bone marrow makes new B cells, hopefully will not make any autoantibody with these B cells. But sometimes, especially patients with immune deficiency, they don't recover their B cells, or their B cells come back and they're not functioning as well, especially if from the beginning. If you have agamaglobulinemia, you're not going to make more. You wouldn't be treating somebody with agamaglobulinemia with B cells, but let's say common variable immune deficiency. if you don't make good antibody, then if you make new B cells, you're still not going to make good antibody because they're essentially the same type of B cell. And so you would need to continue with IVIG. But you're better off if you're getting IVIG than somebody who doesn't have an immune deficiency and then their B cells don't come back and they're susceptible to infection. And sometimes it takes a while before people realize that maybe their B cells didn't recover, and then they need to start an IV gamma globulin. And there are a number of patients who develop poor antibody responses and maybe even agamma globulin anemia after these anti-B cell therapies. And they behave exactly like common variable immune deficiency, except the cause was the treatment rather than something that, although we don't know if there's a genetic predisposition that makes them not recover their B cells. The other common complications are rheumatologic disease, arthritis, lupus, systemic lupus erythematosus, mixed connective tissue disease, and dermatomyositis. And their treatment involves immunosuppressive medications that can suppress the immune system. Steroids were used for a long time. We have more specific immunosuppression now, but also some newer medications, biologic, that target specific pathways of the immune system. So their effect is not as global on the immune system, and certainly, can increase the susceptibility to infection. But again, if you have an antibody deficiency and you're getting IVIG, you're relatively more protected than other rheumatology patients who are not getting immunoglobulin replacement. So important thing is to treat the rheumatologic disease, but continue to treat your immune deficiency as well. Chronic lung disease is a big problem for many immune deficiencies and really a major cause of morbidity, eventually mortality in a variety of immune deficiencies, including common variable immune deficiency. Luckily, it's not too common, but bronchiectasis is damage that really doesn't reverse very well, and mostly you would need more frequent or chronic antibiotics to decrease infection, because the lung now is not clearing itself as well with the bronchiectasis, so it's much more prone to infection. Again, immunoglobulin treatment as well as antibiotics help prevent infection. And so again, keep maintaining your immunodeficiency treatment and adding on treatment for the chronic lung disease with also chest PT and everything else the pulmonologist recommends would be very important. A particularly difficult complication is this granulomatous lymphocytic interstitial lung disease, GLILD. And it's characterized by granulomas, nodules, the presence of both T cells and B cells in the lung. The pathogenesis is not very well understood, and the treatment is also not well understood. People initially, again, started with steroids, other immunosuppression, and I think Dr. Rutus, he was in the Medical College of Wisconsin at the time, found that targeting both T cells and B cells, so B cells usually with an anti-B cell antibody and T cells with an immunosuppression, suppressive medication that targets T cells, he found marked improvement in many of his patients. It didn't catch on much with other investigators, and now people are trying a variety of different immunosuppressive medications. Hopefully, we get to understand this condition better and find better therapy for it. But it's important, of course, also continue your immunodeficiency treatment to prevent infection, because most likely infection will make conditions in the lung even worse. But we really need to learn about this disease better and find the right therapy to improve it. It's encouraging that many patients did respond to the treatment that he gave. So, hopefully we will find ideal, or maybe different patients will need different forms of therapy. think. I apologize. I did talk about rheumatological disease already, so I'm sorry, I doubled up here, but we talked about this already. Gastrointestinal disease, especially if there is protein-losing enteropathy, what happens is that even though you're taking your immunoglobulin replacement, you lose it very quickly in the gut. You can also, if it's really severe protein-losing enteropathy, you can lose T cells and B cells there. And so this complicates immunoglobulin replacement. And the more IV IG we give, the faster the loss. So really you're in a vicious cycle, giving more IVIG and then losing it in the gut. So it's important that the protein-losing enteropathy is treated. Once it resolves, the immunoglobulin levels come back again. It would be worthwhile trying subcutaneous infusion because it's a slower absorption and maybe the loss will be less. So you may be able to maintain slightly higher levels with subcutaneous infusions while there's protein-losing enteropathy. But many immune deficiencies, not just common variable immune deficiency, chronic graft disease, and other immune deficiencies are associated with inflammatory bowel disease, Crohn's type inflammation. It also can result in some protein-losing enteropathy. There are a whole variety of biologics now, anti-cytokine treatments to target inflammatory bowel disease. And sometimes it's a matter of trying one and then the other and then the third. But depending on the condition, hematopoietic stem cell transplant may be an option, especially if the immunodeficiency is somewhat severe. CGD, chronic graft disease, is being treated more often now with hematopoietic stem cell transplant, and that tends to treat the inflammatory bowel disease as well. Liver disease, we did have at one point, just a short period of time, we didn't understand too well about hepatitis C, so some patients receiving immunoglobulin therapy developed hepatitis C, but it can happen from many other causes, and there is now specific therapy for it. But sometimes the liver disease is so overwhelming that a liver transplant is needed. And it may not be a bad idea to consider doing both a liver and hematopoietic stem cell transplant at the same time, or one after the other. It's been done, and this way both the liver disease can be treated as well as the immune deficiency. Now, cancer can also happen with some immunodeficiencies, lymphoma especially, but other cancers as well. Luckily, we have much better at treating lymphoma. It definitely needs to be treated specifically for the lymphoma that's there, but you need to continue your immunoglobulin replacement as well. And it provides a layer of immunity and prevention of infection while you're undergoing the lymphoma. But there, while the chemotherapy does affect the immune system, again, getting immunoglobulin replacement provides you an additional layer of immunity while you're going through that. Whereas other patients with cancer usually don't get treated. Some cancer physicians do look at immunoglobulin levels and provide IVIG if levels drop, but many don't. And the patients who have a large spleen and need it to be removed, ideally, we treat the underlying condition before we have to remove the spleen. But if that happens, those patients are susceptible to pneumococcal infections and as well as meningococcal infections. If you're on immunoglobulin replacement, you seem to be less susceptible. And so again, the treatment for immune deficiency seems to help in those conditions. So the bad news is that many immunodeficiency diseases are associated with immune dysregulation or a predisposition to cancer. But the good news is that if you're getting treatment, especially with immunoglobulin replacement, it's providing you with immunity throughout the treatment of the other diseases. And in summary, we have a large variety of primary immune deficiency diseases that are rare inherited disorders presenting a lot in early childhood, but also later in life. You need a high index of suspicion because everybody gets infections. You have to try to identify patients who have primary immune deficiency. treatment depends on the immune deficiency and the underlying cause. We have also secondary causes of immune deficiency. There are many options for this, for treatment of primary immune deficiency. Immunoglobulin replacement is one of them. We do have associated immune dysregulation and other inflammatory diseases, but we're also having newer medications to target those pathways that affect immune dysregulation. Management of multiple conditions is necessary to manage all the diseases and keep you healthy. Immunoglobulin replacement provides antibody immunity while you're receiving other therapy. And of course, the healthy lifestyle helps prevent complications associated with and the development of diseases that can affect your health. And I guess here I open it up for questions.
Thank you, Dr. Fuleihan. That was an amazing amount of information, and we do have a lot of great questions. I am pulling them up as we are speaking. Okay, our first great question is, what do you recommend for people who have specialists in multiple health systems? My immunologist uses a different EMR. Are there things I should print and bring to those other appointments?
That's a very good question. And luckily, with the same EMR, even at different institutions, you can see a lot of different records. But when it's different EMRs, it makes it more complicated. And that's why I think having a primary care physician who coordinates everything is important, because everything gets to them and then they can also distribute. But you can have your immunologist communicate with your other specialists. They can I think at least the electronic medical records I'm familiar with, you can sort of send the notes to multiple physicians, CC other physicians. But also, you having access to your medical information allows you to share it with other physicians too. And Kat, you have to remind me. I know the Immunodeficiency Foundation had an electronic health record, but I mean, maybe that is stopped right now. But it was designed for patients to store their own data, which they could share with different physicians, especially if they had to move from one place to another. But I think you can still do that with your electronic medical records wherever you're receiving your treatment. You can get your information and share it with other physicians.
Unfortunately, we don't have that feature at this moment, but that is something that we may consider opening up again in the future. But thank you. You bring a lot of good points to that topic. Our next question is, do you have any recommendations for treatment of rheumatoid arthritis for someone who suffers from an IgG deficiency, celiac disease, and fibromyalgia as well? And also, this person wants to thank you for all of the great work that you do.
Thank you very much. I mean, I think for the IgG deficiency, you have to keep up with the immunoglobulin treatments, and I think the treatment for rheumatologic diseases, rheumatoid arthritis, should not impact that, because you're getting the infusions and you would be okay. It's a little trickier with fibromyalgia, and I think there the rheumatologist would be better suited to know if they have to choose different options. They have a lot of options now. It used to be very limited before, but now rheumatologists have a lot of options for treating the different diseases that they have, I think, including arthritis. And so whether I'm not sure if it impacts fibromyalgia or not, but they should be able to know that and choose therapy either that helps fibromyalgia or doesn't make it worse.
And how does CVID impact lymphoma diagnosis? It seems that CVID can light up a CT scan or a PET scan, leading to a diagnosis. And are there CVID lymphoma experts in the USA? This is an interesting topic.
That's a great question. I don't think CVID will light up a PET scan. just because of CVID. So if a PET scan is positive, definitely an oncologist needs to weigh in and try and sort out if this is really important or not. There are other reasons a PET scan lights up. It's really just a measure of metabolic activity. And mostly, cancers will have very high metabolic rate, but there may be situations where you get a false positive. But it's important for an oncologist to make that determination. I think, we depend on oncologists who don't necessarily, I mean, they have to treat the lymphoma. And they don't necessarily have to be experts in CVID, but if they are at an institution where there is an immunologist who is an expert in CVID, that sort of there's communication then with an immunologist and more direct communication, if you like, especially in the record. And so I think that would be where you choose to find an oncologist in a center that has an immunologist or takes care of immunodeficiency as well.
It's important to have both those aspects done. This person has or states that they have ID, MCAS, histamine intolerance, Hashimoto's, lupus, and autoimmune neutropenia. I'm sorry, did I say that right?
Neutropenia.
Neutropenia.
What was the first condition?
ID, MCAS, histamine intolerance.
Okay. Yes. Okay.
As well as Hashimoto's lupus, and the last one is autoimmune neutropenia.
So
And
yes.
they state that they have seen various specialists, and that the best way to motivate what is the best way for them to motivate their doctors to coordinate their care. They've been sick for a very long time, and it seems that their doctors are not coordinated. So what best advice do you have for someone to coordinate care amongst different specialists?
So, I mean, giving an example, of significant immune dysregulation. I think I consider even allergic disease to be immune dysregulation, because we're not meant to have allergic disease, and when we have, but it's very different than the autoimmune diseases that you're describing here. So once there is, especially if there is immune deficiency and autoimmunity, we're dealing with a condition, a situation of immune dysregulation. But even multiple autoimmune conditions without immune deficiency is also immune dysregulation. So this is a relatively, the diseases are not new, but the awareness is relatively new, and there's more and more interest and in immune dysregulation, and more knowledge gained. So I think it's important to find a center where they look into immune dysregulation. Essentially, we would go quickly to doing some genetic testing to try and see if there's any immune pathways that are affected that might be leading to multiple conditions like this. And there are many centers around the country that are doing and looking into immune dysregulation. In fact, at one point I was going to say, where has all the regular immune deficiency gone? Because we're seeing a lot of, and it's not that it didn't exist before, but we have a better understanding for it. So now we're seeing a lot of patients coming to us because they have autoimmune disease and diseases that are not easy to explain. And so, we tend to, of course, we test the immune system, but we also tend to quickly go to either a panel for immune deficiency, or a genetic panel, or even more like a whole exome sequencing or so to try and identify an underlying cause. Maybe 10 years ago, this would be generally academic pursuit to try and find the cause, but nowadays we have treatments that target certain pathways that make a huge difference in some immune dysregulation. And so there is potential. Doesn't mean that every diagnosis will have a treatment, but there is potential to identify a treatable condition. So I think finding a center that looks into immune dysregulation, and you'll see it on their websites when we look at their immune allergy immunology departments or immunology departments.
I think this ties in very nicely with our next question. And then this is something that I find I get asked a lot when I describe where I work for and the demographic of whom I serve. So this person it's their first time hearing of primary and secondary cause of immune deficiency. So how does one determine this? And what is the difference between a primary and secondary cause of immune deficiency?
So primary means really inherited. So there's a known or an identifiable genetic cause for this immune deficiency. And there are, 485, well, some of those maybe are these phenocopies, but I'm sure there are more than 485 right now. There are hundreds of conditions that are associated with an underlying gene defect. We have diseases like still CVID. The majority, we don't know the genetic cause, but we know it is a primary immune deficiency. But if you've had a treatment that can affect your immune system and then develop the immune deficiency, we would call that secondary. Also, post-infectious immune deficiency, so like HIV is an acquired, a secondary immune deficiency, but that's because of an infection. It's more with the therapy, particularly anti-B cell therapy, sometimes other forms of chemotherapy, where afterwards you develop immune deficiency. We still don't know if there is an underlying genetic cause, so that because most people who get these anti-B cell therapy, their B cells recover and then they're okay. But there's a percentage, and it varies depending on the age group, depending on the reason why they got the anti-B cell therapy. So the percentage that don't recover their function is different. But those who don't, we still don't know if there was an underlying cause, so that you would then still call it primary. But in general, now we call it secondary. They got a treatment that affects antibody production, and they haven't been able to recover it. So we call it secondary immune deficiency.
Okay, thank you. Can you please discuss the relationship between PI, positive ANA blood test, arthritis, and chronic sinus infection, and rhinitis?
Rhinitis. Okay. A good one. So the rhinitis is probably a more common cause of sinusitis than an immune deficiency. But so rhinitis can be associated with the sinusitis, as well as immune deficiency, whether primary or secondary, can result also in sinusitis or recurrent sinusitis. The ANA is more of an autoantibody against nuclear antigens. About 5, now people say 10% of the population have an ANA and they don't have any rheumatological disease, but high levels of anti-nuclear antibodies with other clinical features that are associated with rheumatological diseases include, the first one you think about is systemic lupus erythematosus, but other forms of rheumatological other diseases are associated with the positive ANA. But a large percentage of the population have sort of low-grade positive ANA, and it's the rheumatologists don't get excited about this until the levels are quite high, at least 1 in 360 or even 1 in 640 or so. But it also depends if it's just the ANA or there are associated features. Sinusitis isn't the feature for rheumatology necessarily, nor is rhinitis specifically, but they are so common that patients with rheumatologic disease could have rhinitis. Rhinitis is very common.
Thank you. Do you have any statistics or information regarding comorbidity of CVID and mast cell diseases?
don't think so, and I don't think it's come up in a lot of these studies that or registries that have been formed. There are mast cell diseases. They have their own features. They have their own genetic predisposition. Sometimes it's inherited. Sometimes it is what we call a somatic mutation. So some stem cells get a mutation in a gene that affects mast cells, and then you get mastocytosis. This type of gene problem can happens with other conditions as well, and they're called somatic gene defects, meaning that they happen not from birth, but they happen during life. And if it makes the mast cells then get hyperactive, you get a mast cell disease. But there are inherited familial alpha tryptophanemia, gives you much higher tryptase levels. In general, it's reassuring because we worry about high tryptase levels, and if you have a genetic cause for having high tryptase levels, then we're less worried about sort of a more serious condition. But it gives you symptoms and makes you have sort of more severe allergic reactions sometimes. So it's not a benign thing, but it's not a malignant thing either. I think that's the best but I'm not aware. Would have to look some more, and I don't know if we even collect that information on mast cell disease and common variable immune deficiency. This hereditary alpha tryptophanemia is common, so it's possible that patients have both. It's
Okay.
we used to think we were taught in med school also that we have to explain everything with one condition or one disease, and we also thought if you find one gene defect that you got it. But when we started doing genetic testing, and it has happened at Baylor in Texas, in Houston, they found that 5% of immunodeficiency patients had defects in more than one gene. So it's not all, you could have more than one thing.
I think that would make sense. Do you know if there is an association between CVID and liver disease?
Yes, there is. I think it was like 9% in that paper had some form of liver disease. You're more susceptible to infection. Granuloma formation can affect the liver. We still don't understand why some patients with CVID get granulomatous disease or even liver disease, but it does exist.
If a person has CVID with chronically low lymphocytes and chronically low T cells, even on IVIG, I know we can't speak about specific situations, but is it even safe to use a biologic?
A good question. I think it depends on what the purpose of the biologic is and what potential side effects there are. Some CVID patients are more severe than others. And while the majority will have immunoglobulin replacement, there have been a few cases that underwent a bone marrow transplant, hematopoietic stem cell transplant. In general, it's patients who have difficult autoimmune disease with the CVID that it was felt that they needed to undergo. Part of this problem in thinking about a bone marrow transplant is it's not a benign treatment. It has its risks, but at the same time, the sicker you are, the worse the outcome. So, but with CVID, we reserve it to those who are very sick. So but we don't have a good idea of identifying ahead of time who is at higher risk than to have more severe conditions. So that's part of that's why it's not a widespread therapy. But I think depending on the biologic and the reason for it, if it improves health and has less risk of immunosuppression, it's probably worth using it, taking it.
Does chronically low lymphocytes typically signal an underlying infection?
Not necessarily, but viral infections can suppress lymphocytes. So, but that would be transient. Once we recovered from the viral infection, our T cells should come back.
Okay. In your experience, are high liver enzymes common with PID, primary immune?
So we monitor, and I think this was because we were worried about transmitting hepatitis with treatment with immunoglobulin infusions. It's a blood product. But we still continue to watch them. And it's not unusual to find slightly elevated liver enzymes. But if they're higher, then it is a problem and it needs to be, we need to see a hepatologist that figure out, is this from EBV, CMV, another infection? Is it something happening in the liver? And so that needs to be assessed.
Okay. Can you share information on how testing is done for protein losing enteropathy?
Enteropathy. So in general,
Enteropathy, thank you.
you have low albumin, and albumin is a much smaller molecule. So you could lose albumin, but not lose IgG. But you'll find also that IgG is lost. And really is testing the stool for alpha-1 antitrypsin. If that level is high, it means you're losing protein in the gut, and you make that diagnosis of protein losing enteropathy. I'm not a gastroenterologist. There may be other nuances, but in general, that's our thing, is to check for an alpha-1 antitrypsin in the stool. And if it's elevated, then we know we're losing protein in the gut.
So speaking of tests, what tests should be done annually for managing CVID, specifically to make sure no cancers are beginning?
That's right. I mean, definitely need to monitor immunoglobulin levels, make sure you're we're giving the adequate, replacement, both not just by testing the levels, but also by getting a good history, making sure patients are not getting sick too often. We would check the blood count, we check liver enzymes just to make sure there are no complications. We don't routinely screen for cancer, but concern would be weight loss. It's important to look for swollen glands, a large spleen, and if any sort of suspicion for cancer, like for any other person, we would then, refer to an oncologist to have an evaluation done.
Thank you for your informative presentation and answering all these questions. This is such great information.
Thank you.
Do you know if there are any links between low IgG3 and small fiber neuropathy? Neuropathy. And does treatment for one impact the other?
Well, IgG3. So I did my fellowship at a place that described IgG3 deficiency as well as IgG2 subclass deficiency. The IgG2 was really from somebody from infectious disease with the immunologists, but IgG3 came from the immunology group. And so I used to test those levels all the time. Now we don't think they're as important as the ability to make antibodies. So we're much more interested in antibody responses. So I'm offhand like this, I'm not aware of an association between IgG3 subclass and small fiber neuropathy. We used to get a lot of referrals for lower absent IgG4, but now we know there's IgG4 disease with high IgG4 levels. So that would be a good reason to check subclasses. But I'm just unaware if there is something there. I mean, if the IgG3 subclass deficiency is associated with recurrent infections, meaning we're having difficulty responding to vaccines and making antibodies, then the treatment is immunoglobulin. And whether, I don't think it would make the neuropathy worse. I don't know if it would help. But I don't have specific knowledge, so I don't want to say more.
I understand that.
Neurologists use gamma globulin for a variety of conditions, and some of it, they've been FDA approved and all that. So I think having neuropathy, you should see a neurologist who's at least uses maybe gamma globulin, understands the immune system, and can coordinate with your immunologist as well.
Thank you for that recommendation. Are there ways that patients with hypogamma can, yes, who can be,
Hypogamma.
yes, sir, who can be
Yeah.
more susceptible to fungal infections?
So in general,
Are there ways to treat that? My apologies, my phone was
yeah,
glitching.
no, that's fine. That's fine. So in general, antibody deficiency is not associated with fungal infections. If you need to take antibiotics, that sets you up. You lose this protection from the good bacteria, and you can get fungal infections. And you have to treat with an antifungal. T cells are important for cutaneous fungal, for preventing cutaneous fungal infections, and the neutrophils are important for systemic or like bloodstream fungal infections. So somebody with severe neutropenia, uh, whether it's severe congenital neutropenia or secondary neutropenia because of treatments or so, they are more susceptible to fungal and more invasive fungal infections. And that would be but again, there are antifungal treatments from topical to oral to IV, depending on the extent of the disease. Some patients are susceptible to chronic mucocutaneous candidiasis or susceptible to fungal infections because of their neutrophil defect or immunodeficiency, and they are maintained on prophylaxis with antifungals.
This person writes that their primary care doctor and even their immunologist has very little knowledge of PI, and that their health suffers because of this, and they wind up very ill before they will get their infections treated. Are there any suggestions?
So, I mean, in the US, immunology falls under sort of allergy and immunology, and most allergists don't see a lot of immune deficiency. And technically, they are immunologists, but if they don't handle immunodeficiency a lot, they may not be very knowledgeable. And it's just because allergic disease is so much more common and they don't see enough of it, or maybe didn't go a center that has, had a strong immunodeficiency program. So I'm not saying you need to change your doctor necessarily, but if they're not comfortable with immune deficiency, you might want to consult at least, especially if, there's nobody in the immediate area. You can see somebody sort of less frequently at a distance, and then get recommendations back to your physicians. And once I find primary care physicians, once they understand what's going on, they would be more responsive. And whether they're not comfortable using a lot of antibiotics, they would probably check with your immunologist but provide you the treatment.
Thank you. Can you please explain how or why severe chronic fatigue is associated with CVID and Hashimoto's? Any insight would be helpful.
So chronic fatigue is a difficult topic. It was associated with EBV infection, but now it seems to be less so. And but I think it's been recognized more as a condition. But if you have low thyroid levels, you are sluggish, maybe fatigued, maybe tired, and so you really need to treat the thyroid. And it's one of the easiest autoimmune diseases to treat, because if you replace thyroid adequately, those side effects should go away. So you should be okay there. CVID also, if there's sort of low level sort of infection, if you're not being treated adequately, you might sort of be tired all the time because your immune system is sort of working all the time and creating all these cytokines. But if you're well treated, I don't think there should be sort of chronic fatigue, with the exception that we don't know all the causes for chronic fatigue, and maybe we're dealing with an overlap between these two conditions, not just the common variable immune deficiency. But I would look at, are you free of infection, or do you have good levels of immunoglobulin from your treatment? Is there anything else that's been missed? Is there ongoing inflammation or so, to just try and see if there's something else going on, or whether you need to optimize your CVID treatment.
So there are new studies showing that there are types of arthritis that can be caused by infections. What are your thoughts on this?
So yes, there are particularly X-linked agammaglobulinemia, and I guess all agammaglobulinemia patients can have sort of an infectious arthritis with things like uroplasma that's very similar to mycoplasma. And interestingly, many of our X-linked agammaglobulinemia patients come to us from rheumatology. They have arthritis. They're treating them like arthritis, not like an infection. They want to start some either low-dose chemotherapy or biologics, so they get immunoglobulin levels and find out they're none, and then they refer them to us. And it probably was that the arthritis was more of an infection than an inflammation or a rheumatologic condition. So it does exist, but it's not as common in other immune deficiencies. Even CVID, it seems to be more of an agammaglobulinemia type problem.
I am going to butcher this next term, but this person is asking if you were aware of trichomalacia being connected to CVID. And one of
Trichomalacia?
Trichomalacia. Okay, thank you. Are you aware of that being connected to CVID? And my apologies for butchering that.
More with the George syndrome and 22q11 deletion in a newborn. Now, I don't know in adulthood if there's trichomalacia. And while, at Columbia, I do see adult patients with immunodeficiency, but essentially I'm a pediatric immunologist. So if it's adult, it probably would be secondary to an infection or complication. But the George syndrome in children is a deletion on the part of chromosome 22q11 that has a lot of genes, one gene that affects sort of development of the heart, parathyroid, and thymus, and other midline structures. So trichomalacia is one of them. They have poor swallowing. They may have a cleft lip or palate. So the more subtle cases of the George or 22q11 deletion, who may not be picked up by newborn screening for low T cells and may not have low T cells. They may just have some trichomalacia or swallowing problems. And usually ENT will send them to genetics to make sure there's nothing there, and then they find that they have 22q11. But in adults, it would be probably a secondary issue. My guess, infection, but there could be other inflammation causes, but I haven't seen it much or at all actually in adults.
Thank you. In cases where a patient has CVID and a blood clotting disorder, should a blood thinner be taken before starting IVIG? I know you can't speak about specific situations, but your general thoughts would be appreciated.
Yeah, that I have not faced this dilemma. I really think, I mean, there is a risk of clotting with IVIG immunoglobulin products. I would choose going the sub-Q route if there's a clotting issue rather than going straight into the blood. I think the risk of clotting would not zero, but probably reduced by going sub-Q, and definitely have the hematologist weigh in on how significant the clotting disorder is and whether it needs, what degree of treatment it needs and prevention. But that's a very important question, very important issue, because that's one of the worst complications probably of immunoglobulin therapy is when clotting happens. This, depending on where it happens, it could be a big problem.
Mm-hmm. How do you advise your patients to get vaccines when having both CVID and an autoimmune disease?
So whenever I'm evaluating patients for immune deficiency, we like to especially if they haven't been vaccinated recently, we want to see their response to vaccines because, that's how we know there's an immune deficiency. And if they have an autoimmune, like immune thrombocytopenia purpura, I always ask the hematologist, but they always tell me, doesn't matter. I worry that it's going to trigger ITP. And in residency, I had a colleague who developed ITP after getting the hepatitis B vaccine. So it's always stuck with me that, and he was probably going to develop it, and this just happened to be the trigger because an infection may have done it at another point. It's just that our immune system, when it gets activated, if we're prone to autoimmunity, it might trigger our autoimmunity. So for CVID, you're not going to make good antibodies, but you might respond to some, like you're less likely to make good antibody to pneumococcus, but you might still make antibody to tetanus. You may make some antibody to flu, COVID. So we recommend the flu vaccine, COVID vaccine. And it can also stimulate your T cells so that if you do get the infection, it's milder or it gets resolved quicker. We don't have tight data, but there's sort of a sense that at least flu and even COVID, we know there are studies that show T cell function against COVID, but what the clinical effect is not clear. But with flu, it seemed that the duration of the illness would be shorter if somebody was vaccinated. We still leave it up to the parents if they want it, or the patient, in case of adult patients, if they want it. We don't have strong guidelines, although with COVID, we were recommending immunization or even getting anti-COVID antibodies when they were available to help protect patients.
Thank you. And tying in with that, can you have CVID and lupus? So many symptoms overlap, and this person's rheumatologist is telling them no.
You never say never in medicine. But the chances are low, really low, because, it is an autoimmune disease. But we have autoimmune disease in CVID. In immune deficiency. So I don't think it's impossible. But, if you can't make antibody, you're not going to make an ANA. Is ANA driving lupus, or are there other factors? I'm not an expert. I know there was a big debate on are the B cells important or the T cells, and I think both ended up being important. But there were immunologists who felt B cells were driving lupus and others who felt the T cells, but I think both ended up, there's a contribution from both. So I wouldn't say absolutely not, but it's really less likely when you have an immune deficiency to have such a sort of, I guess, the well-defined autoimmune disease. It's easier to make antibody to your platelets or your red cells, maybe, than to have the full lupus syndrome. But I'm not sure you can say impossible, Although I'm not aware of any patient who has both. So I have to say that too.
I agree with you. You never say never, because we're also a believer of when you hear hooves, right? Don't think horse, think zebras. Right. So that ties in with never say never. This person writes that they know that certain diseases such as bronchitis are associated with CVID. However, are rarer conditions being tracked in any way to see if they tie in with primary immune deficiency? For instance, this person had a spontaneous double carotid dissection 3 years ago, and that was such a rare occurrence that they looked to see if it tied into their CVID. They, however, couldn't find any ties, but it made them wonder if anything like that is being tracked, since it was a vascular issue. And do you think occurrences such as these are being looked at to see if there are any ties between immune deficiencies?
I think there are known, although maybe not all are known, but there are known conditions that associate with dissection of vessels that are not related to the immune system. It's more to collagen and other factors. I'm not an expert. So I'm not aware that CVID provides that susceptibility. But I agree that, and it's not something we usually track, although I mean, I think anything that happens to our patients, we ought to somehow be able to collect at least. And then if we see a pattern, that's when we then discover more. So it's important to collect the information. It's just in our registries, we don't ask about everything. But I agree it's important to do that. And a prime example, we always thought X-linked agammaglobulinemia, there's no antibody, you give IVIG, everybody does well. And on the whole, everybody does well. But then in one of our listservs, somebody said, well, do you see inflammatory bowel disease? And the first answers were, we don't see this with X-linked agammaglobulinemia. But then somebody said, I have a patient, another person. And now we know a subset of X-linked agammaglobulinemia patients do have an inflammatory bowel disease that looks like Crohn's disease. And we never thought, but it's when we started communicating. And this is where communication, not just between physicians, between patients and their physicians, and asking questions of your physician that might sort of raise our awareness to think more and ask our colleagues and find out more.
That brings such a good point about self-advocacy and sharing all of the aspects of what is going on with you, with your doctor, and then internally sharing your information along with your colleagues as well. That's a good point right there. And you also tied into our next question, as this person is asking you to discuss how PID and GI issues, either how primary immune deficiency can cause GI issues, and what the overlap is when you also have Crohn's disease.
Yes. So if you have Crohn's disease at a very young age, we call this very early onset inflammatory bowel disease, and the chances of having a defect in an immune gene is much higher. It's not 100%, but it's high enough to investigate and see. And we've learned this more and more. And many of those conditions can benefit from bone marrow transplant, but also now we have a variety of therapies, biologics that would help keep things under control so that you don't have to do something as drastic as a bone marrow transplant. The older you get, when you develop the Crohn's, the less likely it's immune deficiency related. But it is an inflammatory disease. There are susceptibility genes for Crohn's disease. We see them, we pick them up a lot when we're doing panels for gene testing. But if it's just NOD2 as an example, it's a gene. If you have one copy that's has a variant that's associated with increased risk of Crohn's disease, it's only twofold. And Crohn's is rare, that it's not such a high risk. But if you have two copies, then the risk goes higher. And there are other genes probably that give you a risk for Crohn's. So there may be an underlying genetic condition, but not necessarily an immune deficiency. The younger it starts, the more likely there is an immune deficiency related gene. But as we learn more, we might find out more with older onset Crohn's disease.
Thank you. That was very interesting. So we're revisiting the topic of fatigue. When managing multiple conditions, what is the best way to identify the source of excessive fatigue?
That's a good question. I'm not an expert. I would make sure either, if somebody's not on treatment, we assess the immune system, make sure it's okay, or if there is a defect, and find an appropriate therapy. Is it resulting because of chronic or recurrent infections, and we want to prevent those and treat them? Is it because of inflammation? So we can look. We usually look at sed rate and C-reactive protein as a marker of inflammation, but now we can look at cytokines and a variety of different cytokines that tell us about which pathways in the immune system might be. And so if there is evidence of something happening, we would want to try to get to the bottom of it and why it is, to try and find this solution or the answer to it. But there's no one answer.
Be a lot
And
of
there are, I think some infectious disease experts are, interested in chronic fatigue syndrome, and so they might be looking for chronic infections that you wouldn't be able to pick up. You don't not having sort of ongoing fever or it's something easy to see like a sinusitis or an ear infection, and so some of these more chronic indolent infections, they might be better suited to like identify them and then treat them.
That's a good point. Do you outgrow bronchial and tracheal malacia? Well,
That's a good question. We know that patients do better with it as they get older. Is it really outgrowing, or is it that they manage it better, have stronger muscles? I'm not sure. And I would ask an ENT person probably more about the tracheomalacia. Bronchomalacia would be a pulmonologist.
okay. Thank you sincerely for your invaluable time, Dr. Fuleihan, and your expertise this evening. Your medical knowledge and insights are enlightening and greatly appreciated. And we thank you so very much for your time.
Thanks. Thank you.
Thank you. I am going to share some fun information at this point. Just give me one moment to pull up the correct slides so that I can make sure that you all have all of the information. Here we go. So I also want to thank everyone who attended tonight's virtual event. We thank you for your participation and your engagement in the Q&A. Some really great questions that expanded not only the knowledge of you all that's participating, but my own. So I appreciate you all for that. And again, thank you to Dr. Fuleihan for joining us today.
Thank you for inviting me.
Of course. We have additional resources. The Immune Deficiency Foundation has a wonderful website that we just updated where you can use such features as our clinician finder, our Ask IDF, find all of our resources, all of our virtual events, and much more. You can always check us out on YouTube as well. This recording will be up there in about a week's time. And if you ever miss a webinar recording or most of our events, we put on YouTube. Also, I very much encourage you all to check out our podcast called Undiagnosed. It is a phenomenal podcast. Very insightful stories are being shared on that. And for any articles about our presentation, just follow this website and you will be able to find that. Also, excuse me, if your question was not addressed tonight, you can submit your question to Ask IDF. Just visit www.primaryimmunedeficiency.org/Ask IDF or give us a call using the number on the screen. I will make sure that there is a number on the screen. Or Resource Navigator will personally connect you with someone to answer your question directly. So no worries if your question didn't get asked tonight, just go on to Ask IDF. We have a great series within our Ask the Expert virtual webinars coming up. We have one on February 29th, which is Ask the Expert PI and Fatigue. We have lots of questions tonight about fatigue, so there's more information to come on February 29th. And then in March, we have PI and autoimmune conditions. We are excited for that, so be sure to put that on your calendar and check it out on our website in order to register. And I am most excited to share our information about our 2024 PI conference, Real Talk. We're going to be in downtown Chicago. It is from June 20th until the 22nd. Register now. It is a great way to connect with your peers, learn from great presenters such as Dr. Fuleihan, and also thrive in your future. Registration is opened, so again, check it out on our website. The early bird registration deadline is March 31st. So mark that on your calendar. All you early birds get registered by March 31st. Again, it's on our website. So please come join us in Chicago. This is information about our PI conference scholarship application. The deadline to apply for the application is January 31st, and that is next Wednesday. So please get your application in there for a scholarship so that you can attend our PI conference in Chicago in June. All you have to do is email events@primaryimmune.org. Recipients must be a person with PI, and they will receive a discounted registration rate. That'll be $50 for awardee and $25 for additional attendees. In addition, individuals can request hotel accommodations and/or flights. Again, that deadline is January 31st, and it is right around the corner. So please make sure to register and apply for the scholarship application. We want to see everyone there in Chicago in June. We also have Advocacy Day coming up. And it is April 22nd to 23rd. Advocacy Day is a great opportunity for members of the PI community to travel to the nation's capital and meet with members of Congress with a focus on accessibility. IDF will reimburse the costs associated with attending the event, including travel to and from DC, hotel stay, and meals. The number of participants is limited and selected through an application process. Visit our website to apply and email the address listed on the screen with any questions regarding your participation. The application for this, or the deadline for this application is February 22nd. And if you know any teens or young adults who would be interested in Advocacy Day, please have them apply by February 22nd. We have our walk celebration coming up February 28th. We are going to commemorate the impact of the 2023 walk season. We had a phenomenal walk season in 2023, and we're going to provide you a preview of what is in store for 2024. This is just going to be as phenomenal. Our kickoff for our PI walk celebration will be March 27th. And whether you are new to PI or a longtime community member, it's a great way to get involved and learn more about Walk for PI. So mark those dates on your calendar. Thank you again to our wonderful sponsors for their generous support of our educational programming and community services. We could not do what we do without them, so we thank them very much. And most importantly, we want to thank all of you for your participation this evening, as we definitely could not do what we do without you. And once again, I want to thank Dr. Ramsay Fuleihan for his time and his wonderful expertise, and everyone who helps to put this show together. We hope to see you at one of our many events this winter. And of course, we hope to see you in June or in Chicago in June for our PI conference. So just check it out on our website. Thank you all and have a good night. Thank you so much, Dr. Fuleihan. Hope that you have a good rest of your night.